Everyone. So very good evening to all of you, and I welcome you to today's session on the predictor series, on which we will try our best to focus on radiology predictor for you. And my goal is to find out what are the questions that they will ask you in radiology, and my goal is to give you a practice on the style of the exam. So just give me a quick thumbs up in the chat box just to let me know that you are there. And also let me know how many of you are attending the daily morning transform sessions. It is such a pleasure to meet you all in the morning every day. So please be there in the morning at 10 a.m. And today my goal will be to tell you what are the important topics. What are the important topics of okay, my goal is to look at what are the important topics in your INICET paper for radiology, and not only the important topics, my goal is also to look at the important, see the style of the paper, the style, and so that we are able to give you the method of the exam. I'll explain to you. So if I now, before we talk about the questions that I have given, and I'm sure many of you have done them in the emedicoz app, my question is that in the INICET paper, 50% of the paper, which means 100 MCQs, or it means 2 blocks, they are asked from your basic sciences. Remaining 50% of the paper is from your third and fourth year and your clinical subjects. So what happens is, in your clinical subjects, they tend to give priority to medicine, surgery, obs gynae, and PSM. So in the clinical subjects, they tend to give priority to classically surgery, obs gynae, PSM, and medicine in a more integrated manner. Now my question to you is, then if you are going to have majority of the paper from the larger clinical subjects and your basic sciences, what is the status of the short subjects? So the short subjects are represented less in the INICET paper. So this is the first observation that I want you to know. The short subjects are given more weightage in your NEETPG exam as compared to NEETPG, less weightage in your INICET paper. So how do we tackle that? And also the short subjects, especially radiology, they use the buzzword called as integration in the exam. A lot of questions will be integrated with anatomy, with management, with pathogenesis, and I'll give you the idea behind it. And also they will try to use different methodology like match the following. One of the classic radiology question in the paper will be match the following. They will write on one side the radiological signs, on other side they will write you the disease, and you will have to match the following, or one side investigation of choice and you have to match the investigation of choice. And the second thing is, they will give you a combination type of answer question, where the question will be answered will be 1 plus 2 is correct, 1 plus 2 plus 4 is correct, like that. And the fourth pattern that they use are assertion reasoning, and they use a pattern called as arrange the following in sequence. Arrange the following in sequence. So today in my paper, I have tried my best not only to give you the idea of the topics that they ask in radiology in any set paper, but also the style of the exam. So I have spent a lot of time in building these questions. They are there on your emedicoz app as a practice test. And those of you who have not given the test, you can actually give it directly on the app itself. So every day in the predictor series, and we will do a predictor series for your NEETPG also later on, and FMGE exam also later on. So do subscribe to the channel so that any particular lecture that we are conducting, you should never miss out on. You should never miss out on any particular topic. So what have we discussed so far? Let me quickly tell you. The paper primarily will be first and second year subjects, and the bigger clinical subjects, medicine, surgery, obs and gynae, PSM. Then the third year and short subjects will be represented in a less manner. The ENT, opthal, medicine, the skin, anesthesia, radiology, psychiatry, orthopedic would have a lower number of questions as compared to the classic pattern. So if you are clear with this, second thing I wanted you to understand is the approach. The approach that we will have to keep will be different style of questions. Second approach we need to know is integration. They will not be pure questions, they will all be integrated questions. And the third thing I want you to keep in mind is time management. The questions of this tricky sort, they take more time to solve. So in your exam, the main thing will be time management. And I'm sure many of you attempted the INICET CBT that we had recently conducted. Very important. Please make sure that you practice mock tests and your CBTs to get the hang of the real paper. What else will we do in near future? In near future, DAMS will also conduct on YouTube NEETPG and also FMGE Predictor series. On the app for our subscribers, we will conduct the PYQ ka BAP sessions. After the INICET paper, we will conduct them for NEETPG and FMGE exams. So we will, just in the same manner like we are supporting you right now for your INICET paper, we will continue the support for later on for your NEETPG and FMGE as well. Okay. So with these basic ideas, I want you to see the first question in front of you. What is the question like? The question says, let's see how many of you are able to answer. The question says, MRI is superior to CT for which of the following? And you can see there are 4 choices that I have given, and I have given combinations. This is the unique pattern that they follow in your INICET paper. This is the pattern that is not there in NEETPG. NEETPG only you have to find one answer. INICET paper you need to find the combination. Let us see if you can answer. Acoustic neuroma. What is acoustic neuroma? Acoustic neuroma is a brain tumor which is arising from the vestibular division of the 8th nerve, and it is a schwannoma. Any nerve or brain tumor, usually the investigation of choice is a contrast MRI. So definitely MRI is superior to CT to see a acoustic neuroma. What is multiple sclerosis? Multiple sclerosis is a white matter demyelinating illness. To see white matter disease, to see acute demyelination, again the investigation that we need to do will be a contrast MRI. Calcification. C for calcium, C for CT. Any part of our body where you have calcification, you always do a CT. And the preferred CT for calcium and brain hemorrhage and stone will be NCCT. Let me repeat. NCCT is preferred for calcification, clot and stone. So you saw this question last year in the INICET paper also. Urinary stone. The answer is NCCT. NCCT. Okay. And demyelinating illness or MRI, contrast MRI. Soft tissue. If you remember from all my classes, I always tell you soft tissue, muscle, soft tissue, cartilage, tendon, ligament, meniscus, always do a MRI. So the soft tissue sarcomas, again a contrast enhanced MRI should be done. Any neoplastic illness, any neoplasm or cancer, you always give contrast to see the vascularity of the tumor. Any inflammatory lesion, we give contrast to see the hyperemia associated with inflammation. So 1, 2 and 4 are correct. The answer is B. Are you able to understand the pattern? So did you notice the question was straightforward, very simple. The only difference that happens in the INICET paper is that you have to think and find out what is the answer. So let me ask you some questions now. All of you in the chat box, be ready and tell me now. What is the investigation of choice for brain tumor? Any brain tumor. Let me know in the chat box. Any brain tumor. Answer is contrast MRI. Contrast MRI. Multiple sclerosis. Contrast MRI. What is the finding of multiple sclerosis on MRI? Name the finding. Name the finding of multiple sclerosis on MRI. Any one of you can answer. Dawson's finger. Dawson finger. What else? Do you remember any finding that I described to you in the DAMS DVT where the findings are disseminated? Tell me, in multiple sclerosis, the findings are disseminated in, anyone? Space and time. Disseminated in space and time. So always remember these things. Inflammatory lesions, give contrast. Calcium, non-contrast. Brain hemorrhage, non-contrast. Head injury, NCCT. Are you clear with this or not? Yes. So I am super happy with the answers that you're giving in the chat box. I know कि अपना टाइम साला आएगा नहीं, अपना टाइम अपन खुद लाएगा. तुम सब ला के आओगे, मुझे पता है. करके देखते हैं, ठीक है? Okay. So let's see the second question. Second question what I created was a special question for INICET pattern. Every 1 or 2 years I see 1 or 2 questions on this pattern. The pattern is called as, anyone? Assertion-Reasoning. Assertion-Reasoning. How to solve them? Always try to see in a assertion-reasoning question, always try to see both statements separately. Let us see the first statement. PET-CT is ideal for identifying viable tumor tissue post-chemotherapy. So what is PET-CT based on? PET-CT is based on glucose metabolism. It uses FDG. So it is likely, we can actually see the logic, it is likely that a viable tumor tissue will have metabolism. So it looks like a correct statement, true statement. Second line says, PET-CT uses technetium-99m which accumulates in the necrotic tissue. Definitely it is a false statement. Technetium-99 is used in a routine nuclear scan. So the PET-CT uses commonly FDG, fluorodeoxyglucose. So what do you think? Assertion is true, reason is false. The answer is C. This is the style only used in INICET paper. Once in a while they have 1 or 2 questions on the assertion reasoning pattern. Now let me ask you again. Again we'll do the same thing again. Okay. Let us see how many of you are able to answer. Ready? So what do we use most commonly in the PET scan? We use FDG, fluorodeoxyglucose. Now I want you all to answer what is radioactive in the FDG. What is the radioactive part of FDG? Anyone? 18 fluorine. So only thing that you need to type in the chat box is what is the half-life of 18 fluorine? Any one of you? What is the half-life of 18 fluorine? Anyone? It is 110 minutes. 110 minutes. Okay. Are you clear? Second question. Any one of you can answer. Beta. Okay. So what is FDG? FDG is a glucose analog. And cancer cells are constantly glucose hungry. Can you tell me why? Because even in aerobic environment, the cancer cells undergo glycolysis. They don't undergo Krebs cycle, which is called as the Warburg effect. So the cancer cells are constantly glucose hungry. So now you need to tell me, if a cell is glucose hungry, what will you see? It will have increased expression of GLUT transporters, GLUT receptors on the surface. If a cell has increased amount of GLUT receptors, it will have increased uptake of glucose, increased uptake of FDG. This is the reason why. We use PET scan for cancer staging. We use PET scan for response to therapy. Okay. Now my question to you is, can you name, let's see if you can answer, can you name any non-cyclotron PET isotope? FDG is produced by cyclotron. Can you name any non-cyclotron PET isotope? Anyone? So the answer is 68 gallium. 68 gallium. So always remember, if they say in the exam gallium 68 DOTA-TAT PET. If they say in your INICET paper gallium 68 DOTA-TAT PET, can you tell me why it is used, where it is used? If you tell me in the chat box, I'll be very happy. It is used for, remember I told you this in DVT also. Gallium 68 DOTA-TAT PET is used for neuroendocrine tumor. Neuroendocrine tumors. Now my question to you is, if I replace this gallium with lutetium, and if I say lutetium DOTA-TAT, now this lutetium is a strong beta, weak gamma emitter. Strong beta, weak gamma emitter. Now if you have attended any of my classes, you will know if an isotope is a beta emitter, it will diagnose the tumor or kill the tumor? It will kill the tumor. So lutetium dotatat is the therapy used in neuroendocrine tumor. Name the therapy. What is this therapy called as? Future INICET question. This therapy is called as PRRT. PRRT. What do you mean by PRRT? Peptide receptor radionuclide therapy. Peptide receptor radionuclide therapy, PRRT. So this is what is used in neuroendocrine tumors, and you will be surprised both of them are previous INICET questions. So these are the questions which are based on PET scan and the new updates. So if you are able to do it, it is a very good idea. But don't forget, so far I have shown you two patterns. One was multiple combination, second pattern is assertion reasoning. These are the patterns which are unique for your INICET paper. You don't have these patterns in the NEETPG exam. Okay. Now let's see another pattern. Now you will appreciate now that when I was creating this test paper for you for the morning session on the emedicoz app in the daily quiz session, I thought that we should include the style of the exam also, not just the topic. So I already told you the style of the paper is, anyone tell me what is the style? Match the following. In the match the following, they put the idea behind INICET is, on one side they write the radiological sign, on the other side they write the condition. So now please look at the image and tell me bird beak sign seen in. Bird beak sign. So the best answer will be achalasia cardia. Almost every time in your NEETPG exam, in your INICET paper, they have asked achalasia. Apple core appearance. Apple core appearance. Carcinoma colon. So remember, cancer of the bowel leads to the apple core appearance, the overhanging edges, the shouldered appearance. Corkscrew appearance. Diffuse esophageal spasm. Double bubble appearance. Duodenal atresia. So it is going to be A is 2. So if the A is 2, choice number D is ruled out. Either it is B or C. Okay. B3. That means the answer is B. So I hope you notice that in the match the following, sometimes you don't need to look at all of the answers. Even if I know one or two, I'm able to get to the answer. The only thing about match the following is time management. You need to know how to manage your time well. You will see exactly the same pattern that I'm telling you in your INICET paper. Now I hope you understand that the goal is not radiology. Radiology is not the most important subject for INICET. INICET, 50% of your paper will be basic sciences. Remaining 50% majorly will be contributed by surgery, obs and gynae, PSM, medicine. Then ENT, ophthal and short subjects will fall into place. So it is not the key, but the key is the pattern. So that is why I thought my duty is to show you the pattern. This is how a match the following is asked. Always remember, match the following. Always remember the trick. If you are able to rule out two answers, usually it becomes automatic. If you are able to go to two answers, it becomes automatic. So don't be scared of the pattern. It is actually easier. Just to remind you, if you remember in your school days, you had the NCERT books. Okay. The only thing that can make a difference in the exam is the syllabus is same. The method of asking the question changes. Same thing that they are using in your INICET paper. The method is different from NEETPG. I'll show you another example. This time in this question, I have made a match the following with investigation of choice. So you have to tell me, out of the choices given, why would you do a HRCT chest? Out of the choices given, why would you do a HRCT chest? HRCT chest will be done for ILD, interstitial lung disease. So A is 2. So A, this is not the answer, this is not the answer. Either B or D. PET-CT. PET-CT will be done for metabolic tumor assessment. I already told you, PET-CT done for tumor metabolism, glucose metabolism. So B is 4. So it looks like this should be the answer. Ultrasound abdomen. For gallbladder, we always do. For liver, for gallbladder, we always prefer to do an ultrasound. For liver, for gallbladder, we prefer to do an ultrasound. So Now C3, this looks like to be the answer now. Okay, MRI brain with diffusion weighted, stroke, infarct. The answer is 1B. So if I just quickly revise, these are also the previous INICET questions in different method. Once in INICET they have asked, if a patient has clinical suspicion of interstitial lung disease, what investigation will you use to characterize? HRCT. HRCT. If you see basal honeycombing, traction bronchiectasis, the pattern is called as usual interstitial pneumonia pattern, irreversible damage, poor prognosis. You remember from my class. Which investigation can detect brain infarct earliest? Brain infarct can be detected earliest by, type in the chat box beta, diffusion weighted MRI. Gallbladder stone, acute cholecystitis, jaundice, hepatobiliary, ultrasound. Remember, jaundice, ultrasound, gallbladder stone, ultrasound, acute cholecystitis, ultrasound. Okay, so I hope you get the pattern now. The idea is those same things that we study in every class. In INICET paper, they try to make it in a different pattern. The packaging is different. So if you ask me, other than single best answer, the most favored pattern in INICET for radiology will be match the following. Single best answer ke alawa, the most important pattern will be match the following. Keep this in mind. Match the following is very important. And in radiology, match the following is only made by two ideas. Remember the two ideas. Radiological sign, disease. Investigation of choice, indication. This is the most important thing that I want you to remember for INICET. For NEETPG, these are 4 different MCQs. INICET, this is a single MCQ. Are you able to get it now? Okay, beta. Very good. Let me ask you some questions and we will do them together. Okay, beta. Last INICET paper, remember, urinary stone, investigation of choice. Gallstone, investigation of choice. Can you fill up the gaps now? Urinary stone, if they say, just like the last INICET paper, the answer will be NCCT. But if they say gallstone, then the answer will be, anyone? Then the answer will be ultrasound. Then the answer will be ultrasound. If they say acute cholecystitis, what will be the investigation of choice? If they say acute cholecystitis, the investigation of choice will be ultrasound. A previous INICET question, what will you see in acute cholecystitis on HIDA scan? Let me know in the chat box. What will you see in acute cholecystitis on HIDA scan? HIDA is hepatobiliary immunodiacetic acid. On HIDA scan, acute cholecystitis, you will see non-visualization of gallbladder. Non-visualization of gallbladder. It is paradoxical. The gallbladder is swollen, but it is not visualized. Keep it in mind. Very likely question in the exam. Also remember, INICET paper, they are liking to ask, they love to ask things which have air in it. So it is possible they might show you a diabetic patient with air in the gallbladder wall. What will you think? That is a gangrene, emphysematous cholecystitis. So they like to show you air in the lumen of the gallbladder, or it's a very possible question. Emphysematous cholecystitis is a very possible question, and the key word in the paper will be patient will be diabetic. Also, if they say air not in the gallbladder, if they say air in the biliary tract, if they say air in the biliary tract with small bowel obstruction and a radio-opaque stone, can you tell me in which condition do we see these three things? If there is air in the biliary tract, pneumobilia, small bowel obstruction, and a stone, then what is the condition called as? This condition is called as gallstone ileus. And can you tell me what is this sign called as? Wriggler's triad. Wriggler's triad. Then the sign will be called as Wriggler's triad. Okay. So after the session, this PDF that I'm making, I'll upload on the DAMS official Telegram channel. If you're not following it so far, please follow the Telegram channel. please subscribe to the YouTube channel so that you don't miss out on any important notification. Okay, so let us see the next question. Tell me the style. I have used the PYQs, but I have converted them into match the following. Now tell me, nuclear medicine and use. Why would you use, anyone? Why would you use, anyone? Let us see, technetium DMSA. Where did I teach you technetium DMSA in my class? Technetium DMSA is used to see renal cortex. If you remember, S for structure, S for structure, S for scarring. Technetium DMSA is, it's like accumulated in the renal cortex. So if you have renal scarring due to vesico-ureteric reflux, due to chronic pyelonephritis, you can see it on a DMSA scan. This is a previous INICET question. Investigation of choice for renal scarring is technetium DMSA scan. Now you also, another previous INICET question is technetium MIBI, Sesta MIBI scan. Can you tell me why would you use this word technetium MIBI, or we are writing here Sesta MIBI scan? One of the most important, very favorite question of your INICET paper is Sesta MIBI. It is used for parathyroid. Why? Where did I tell you gallium dotatat? Again, previous INICET question, new style. Question is PYQ only. The answer is, anyone? Neuroendocrine tumor. And if you can tell me, where did I tell you FDG? Can you tell me in the chat box? I am sure many of you will be able to answer. All the students, tell me. The answer is cancer oncology. So A is 1 and there is only one choice with A is 1. The answer is this. Are you able to do it? So are you able to understand what I am doing is, I have created this test paper only with the previous questions and the previous topics, but I have kind of mixed it all up in a new style, new packaging. This is what you will feel in your real INICET paper. During the exam, you will feel that the paper is doable, it is from your previous year topics, it is from your mission INICET in the short course. The packaging will be different. This is the style. They want you to think. And I am telling you, you will come back when I am taking your interview here in this channel. You will come back and say, Sir, wohi tha, lekin sochna pad raha tha. You will see every topper say this. Second thing I want you to remember is, these questions will look tough. Don't panic. Attack. All the toppers go more aggressive in the paper. If you have attended my class, do you remember the rule for INICET? The rule for INICET is, anyone? If you are able to rule out two choices, tell me, what will you do? If you are able to rule out two choices, what will you do? Attack. You have to attack. Toppers are doing more than 190 questions. If you have no idea about four choices, if you have no idea about all four choices, defense, leave that question. Keep this in mind, beta. Keep this in mind. Very, very important. Okay. Let us see now. They always like fast. And I have now created for the first time a new pattern question where I am saying, arrange the steps in trauma fast protocol. Arrange the following in sequence. Anyone, beta? What is fast? What is fast? Fast is focused assessment with sonography in trauma. You will be surprised, sir, why are you writing this previous INICET question? Focused assessment with sonography in trauma. If you see the thoracic cavity also, if you include the thorax evaluation, please tell me in the chat box, what do you call it? If you remember, if you say thoracic evaluation, then it is extended fast, E-fast. What are you trying to look for? We are trying to look for hemoperitoneum. If there is hemoperitoneum, it indicates solid organ injury. It indicates solid organ injury. Are you able to do it, beta? Yes? Okay. So let me ask you a question now. Which abdominal injury can be missed on fast? Remember, they will always ask you, the answer will be retroperitoneal, previous INICET question, hollow viscous injury, mesenteric injury, diaphragmatic injury. These are the injuries which can be missed on fast. Okay. Now, another question that they like asking is, if the fast is positive and the patient is stable, what will you do? Fast positive means that there is hemoperitoneum. If there is hemoperitoneum, you are thinking of solid organ injury. If the fast is positive, patient is stable, you will do a, anyone in the chat box, CECT. If the fast is positive but your patient is hemodynamically unstable, what will you do? Tell me. If the fast is positive, patient is unstable, there is no time for CT. There is no time for CT. Then what will you do? Directly take the patient for exploratory laparotomy. Directly take the patient for exploratory laparotomy. Are you able to do it, beta? Okay. Now, but the question in this paper was about sequence. So whenever we do fast, I want you to be very careful and answer. We keep the probe first in the subxiphoid area. I keep the probe first in the subxiphoid area to look for cardiac tamponade. Then the right upper quadrant or right flank to see the Morrison's pouch. Then the left flank to see the linorenal recess. Then pelvis. So the sequence is pericardium, Morrison pouch, linorenal, pouch of Douglas. Okay. So this question answer will be A. Are you clear? So the sequence of fast is, you keep it in the subxiphoid area to look for cardiac tamponade. Right flank to see the Morrison's pouch. Left side to see the, anyone? Linorenal recess, and pelvis to see the pouch of Douglas or the rectovesical pouch. Clear? Okay. So the sequence is 1, 2, 3, 4, and the style of the question only asked in INICET is arrange the following in sequence. This is called as arrange the following in sequence. I can see a question in the chat box, so let me answer. If they say renal trauma, beta, renal trauma, and they ask you investigation of choice, it will be CECT. Renal trauma investigation of choice CECT, but if the patient is unstable, what will you do? Anyone in the chat box, renal trauma, patient is unstable, what will you do? Then the answer will be single shot IVP. You want to see the function of the opposite kidney. The answer will be single shot IVP for an unstable patient. Stable patient, CECT. Investigation of choice, CECT. Okay, done. Very good. Again, you will see a pattern. The pattern is very standard that I am using. I am using the standard and the style of your INICET paper. This is called as multiple combination style. This is called as multiple combination style. Which of the following is a common feature in chest X-ray for heart failure? This is the question, beta. Okay. So let's see the first line. Cephalization of blood vessels. Correct? Yes. The first X-ray feature is redistribution of blood flow. The blood from the lower lobe is redistributed to the upper lobe, and you will see the cephalization of blood flow. Then you have interstitial edema, which is seen as curly lines. You can have pleural effusion, bat wing appearance also in your heart failure patients. But you will not have hyperinflated lungs. Can you tell me why? Hyperinflated lungs is a feature of emphysema. It is not a feature of heart failure. So, if they say hyperinflated lungs, then we will think of emphysema. Then we will think of things like smoking, alpha-1 antitrypsin deficiency. So, the answer is 1, 2 and 3. Okay. So, what are the X-ray signs of heart failure? The first sign is, remember, is cephalization or redistribution of blood flow. Then we have interstitial edema, which is seen as curly B lines, then curly A lines. B lines are seen at the lung base, starting at the pleura at the lung base. Then remember, you have the alveolar edema, which is seen as the bat wing appearance, and you can have pleural effusion in the heart failure. Okay, so these are the X-ray features of heart failure. But the style is, it is a standard question that we discuss in every one of our class. The only difference is the style. They have given multiple combinations. Okay, beta. Now tell me, how will you differentiate non-cardiac pulmonary edema with the heart failure on chest X-ray? Non-cardiac edema, there will be diffuse opacities in the lung. While in cardiac or the heart failure or cardiogenic edema, there will be bat wing distribution. In non-cardiac edema, where we can actually say it as ARDS, there will be diffuse opacities. What about cardiac size? Cardiac size in non-cardiac edema will be normal. PCWP, normal. Usually, curly B lines and cephalization are not considered a feature of ARDS. So curly B lines and the cephalization, bat wing appearance are seen more in the heart failure, not in the non-cardiac edema. And whenever they want to make a question on non-cardiac edema, they will use a systemic inflammatory process as the clue in the question. If anyone had given the last NEETPG, the question was patient with acute pancreatitis is breathless. That was ARDS, non-cardiac edema. Or they might use an example of sepsis. Okay. So what is happening is, in ARDS, in a systemic inflammatory process, your pulmonary capillaries are leaky and the lungs become white. And we have talked about this in our different classes in live rapid revision. I have talked about in DVT and the regular classes. Definitely we have talked about. So I hope now you understand the idea behind INICET is they have to make it more integrated. They have to have different style of questions. I'll give you another example. Now, this is a previous INICET question. This is called as the image based question. Image based question. Patient has a history of trauma. If the patient has history of trauma, this is your liver, this is your right kidney. Do you see any black area between liver and kidney? Yes. Do you see this black area between liver and kidney? Yes. Then what is it? This is fluid. In trauma patient, what fluid can happen in the peritoneum? Blood. This patient has hemoperitoneum. If you have hemoperitoneum, it is called as, tell me, what will be the answer? It is hemoperitoneum. It is called as fast positive. It is called as fast positive. They can simply ask, what will be your next step? If the patient is stable, you should be doing a CCT. If the patient is unstable, you will go for exploratory laparotomy. Exploratory laparotomy. This is the image showing you the Morrison's pouch. Okay, and this is a previous year question as well. This has been asked in a previous INICET paper. I have directly taken the question from a previous year question. Just to give you an idea, the method that I want you to understand is, INICET is a predictable paper. NEETPG, not predictable. INICET, they tend to repeat the same topics again and again. For that, I would strongly recommend that you go to your short courses in the app and revise your mission INICET before your INICET paper. Sir, is it optional or must do? This is must do. Okay. So don't forget that even if you are, not sure about that, do I have a chance in the Central Institute or not? Still, you need to give yourself the best chance. And to give the best chance, you need to revise this course. It is there in your short courses section. Even if you are a deadly combo subscriber, you will see it there in your short courses. It is very important to see this because it is a predictable paper. They have repeated fast multiple times. So it is likely that the same topic, a new question might be asked. The second style is a image based question but with a clinical stem. This is the question where this patient has flank pain, some fever, recurrent UTI, alkaline pH in the urine, and there is a stone visible on the X-ray. Can you tell me what is the stone? This is called as the staghorn stone. If you see a staghorn stone in a patient with UTI, with alkaline urine or proteus infection, you have multiple leukocytes, UTI, then you always think of struvite stone. You always think of struvite stone. What is struvite? Triple phosphate. Then we think of triple phosphate. And the idea is, instead of asking, remember, instead of asking your direct image, they are giving a clinical question and integrating. So what I am saying is, in radiology, either I am expecting them to put one or two match the following, or one or two integrated questions with a clinical specialty. Okay. Now, if you are clear with this, let me ask you a question. So always remember, when you will go to your short courses, if you have not done them so far, there will be a small course on the DAMS app called as emergency room. Again, a must do thing if you are weak at emergencies. I have seen in your paper there are some zones which are very important. Emergencies are important for NEETPG, emergencies are important for your INICET. Even for USMLE, emergency is very important. Can you tell me why? Because our MBBS doctor is supposed to know how to deal with emergencies. Second important thing is TB HIV. Very important for NEETPG, FMGE, and remember in INICET HIV is always a possible question. Let us look at the HIV question here. This is a question based on HIV. This patient is HIV positive. CD4 count is low. There is some visual impairment, hemiparesis, neurological and visual problem. MRI shows asymmetric white matter hyperintensity with no enhancement in the parietal and occipital lobe. Okay. Now you have to tell me, anyone, is the answer toxoplasmosis? Toxoplasma is a very important opportunistic infection in HIV. Is this toxoplasma? No. Why not? Toxoplasmosis will be seen as ring enhancing lesions. CNS lymphoma again in HIV patients will be ring enhancing lesion. CNS lymphoma is a tumor, toxoplasma is an infection, would have a ring enhancing lesion. So if we see white matter abnormality with no enhancement in a patient with HIV, I am thinking of an opportunistic infection by JC virus. This JC virus involves the oligodendrocytes. If the oligodendrocytes are involved, any one of you can answer, then if the oligodendrocytes are diseased, then the myelination will be affected and you will have multiple multifocal white matter abnormalities, which is called as PMLE, progressive multifocal leukoencephalopathy, which is the answer to the question. So in NEETPG they like TB and HIV both, but in INICET usually it is the HIV. Okay, so it is easy to predict the paper for your INICET paper in radiology. Either they will make one match the following, one integrated question with either clinical or anatomy, remember, one HIV or some immunocompromised state, and one we can put a question on some trauma or non-trauma emergency, like that. Okay, so if you are clear, now I see a question saying, sir, in which condition do we see bilateral temporal hyperintensities? Okay, anyone? Let's see if you can answer better. In which condition will you have bilateral temporal hyperintensity? Which kind of encephalitis? HSV1. Then you think of herpes simplex virus type 1. This is again a previous NEETPG question. Herpes simplex type 1 HSV encephalitis causes temporal lobe predication in encephalitis. Are you able to do it? Okay, very good. And I can see many of you are able to answer in the chat box. I'm super proud of you, but super proud. Okay. Now, Anyone? If they say ring enhancing lesion in HIV positive patient, most likely answer will be CNS toxoplasmosis. Okay. But if they say a HIV positive patient has soap bubble like appearance, soap bubble like microcysts in the basal ganglia, what will you suspect? Anyone? If they say HIV positive patient has soap bubble like appearance, microcysts, pseudocysts in your basal ganglia, this is discussed in my, this is a previous INICET question discussed in my DVT session. Anyone can tell me, then the answer will be cryptococcal meningitis. Then the answer will be cryptococcal meningitis. Are you able to do it? And if they say HIV positive patient has reticular opacities on the chest X-ray along with pneumatocele formation. Remember the negative line, no lymph node enlargement, no pleural effusion. What will you suspect? If a HIV positive patient has reticular opacities in the chest X-ray, pneumatocele formation, no pleural effusion, no lymph node, then what will you think? You will think of pneumocystis jirovecii pneumonia. Pneumocystis jirovecii pneumonia. Are you clear, beta? And I'm very happy that all of you are able to answer each of these questions. Then I have seen this is again a adapted question from 2024 INICET paper. This patient has sudden severe headache. Let me just highlight the question. Sudden severe headache, you are suspecting subarachnoid hemorrhage. If you are suspecting subarachnoid hemorrhage, you have done CT angiogram, and you see an aneurysm in the anterior communicating artery. So once you have a SAH, what is the risk? The risk is rebleed. In the next few hours, the patient can have a rebleed. If the patient has a rebleed, it can prove to be fatal in most of the cases. How will you prevent? What will you do now? What is your management? This is May 2024 INICET question, but the language I have changed. Now you need to do a endovascular coiling. You will put platinum coils in the aneurysm to prevent rebleed. To prevent rebleed. The answer is not clipping, beta. Clipping is surgical, neurosurgical. It requires craniotomy. So, out of the two, what is the next best step? Then the next best step will be endovascular coiling. Coiling was asked as a question. It is a question based on interventional radiology asked in the INICET May 2024 paper. So what they have asked is that you will fill up the lumen of the aneurysm with platinum coils to obliterate the aneurysm and prevent rebleed. Let me make another question. Another complication of SAH is vasospasm. Can you tell me what investigation will you do to detect vasospasm in SAH? Tell me. In what investigation will you do to detect vasospasm in a patient with SAH? You will do a transcranial Doppler. You will do a transcranial Doppler. Can you mark this in the exam? To see the velocity, to see the vasospasm, and to see if you want to give any calcium channel blockers. So the investigation to look for vasospasm in a patient with SAH is transcranial Doppler. This is again a possible question on the same topic in the future exam. Also, another question that I feel that they can ask is ADPCKD. What investigation will you do in the brain in patients of ADPCKD to screen? How will you do the brain screening in a patient with autosomal dominant polycystic kidney disease? So we know patients with ADPCKD can have aneurysms. So you need to do screening with MR angiogram to look for associated berry aneurysms. You will do a MR angiogram to look for berry-aneurysm. This is a previous INICET question. Many people get it wrong. They mark CT angiogram, which is not right. Answer is MR angiogram. CT angiogram is the usual IOC for cerebral aneurysms. But when we talk about screening, we want the test to be totally harmless, no radiation. So screening for cerebral aneurysms, the answer is MR angiogram. Investigation of choice for cerebral aneurysm is CT angiogram. Are you able to do it, beta? Okay. So these are some possible questions on the topics that they have asked. Now I will show you a topic that I am predicting now, that they'd like to integrate anatomy with radiology. Anatomy with radiology. Okay. Clear? Okay, beta. Let's try. A chest CT, try to answer. In a neonate shows an aberrant artery arising from aorta supplying the left lower lobe of lung with no bronchial communication. Can you tell me what condition am I talking about? Anyone? So we know by now. Try to understand. Try to follow. Okay, I'll just draw some anatomy and then we'll talk about it. If this is my foregut, suppose this is my foregut. From the foregut, the lung bud will arise. So lung arises from the foregut. Then this lung bud will divide into two and form both the lungs, and the mesenchyme will form the cartilage and the vessels, etc. But I want you to imagine, suppose after the lung bud has formed, another lung bud forms and it will form a segment of the lung. Will this segment, which is formed by this extra lung bud, this segment will not communicate with the bronchial tree. This segment will be cut off from the bronchial tree, cut off from the pulmonary circulation. Okay. And this segment will receive the blood supply from aorta. It will receive the arterial supply from aorta. And the child will come to you with recurrent chest infection. What do you think we're dealing with? Recurrent chest infection. This is called as bronchopulmonary sequestration. Bronchopulmonary sequestration. But don't get confused by the choices. Congenital lobar emphysema is most common in the left upper lobe. It is not supplied by aorta. It is a emphysematous lobe in the upper lobe in a newborn, left upper lobe. Bronchial atresia, we can just skip it here. Cystic adenomatoid malformation is multicystic area in the lung in a newborn with the diaphragm being intact. So remember, if you see multiple cysts in the lung, multiple air-filled cyst lucencies in the lung in a newborn, think of cystic pulmonary adenomatoid malformation. Okay, and also remember, if you see cystic lucencies on the left side posteriorly, if you have air-filled cystic areas in the left lung posteriorly, you should think of Bogdelic hernia. Due to patent pleuroperitoneal canals, you have to think of diaphragmatic hernia. If you see cystic lucencies on the left side, scaphoid abdomen, the heart is pushed to the right side, keep in mind left posterior will be Bogdelic hernia, right anterior will be your Morgagni hernia. So these are some possible questions in the exams. Okay. So the question, some possible questions in the exams are these. But if they want to make it more tough, they will ask you a question like this. Let's see if you can answer. Sequestration is of two types. Intralobar, extralobar. Intralobar is within the same pleural covering. So if the sequestered segment is within the same pleural covering, it will be intralobar. And I hope, I see a bacha saying, sir, why this is not adenomatoid malformation? Adenomatoid malformation will not be supplied by aorta. Did you notice the keyword here? Keyword was aorta, beta. Aorta, systemic supply, aorta is sequestration. So if the sequestered segment is within the same pleural covering, it is intralobar. If it has its own separate pleura, then extralobar. Arterial supply for both will be aorta. Venous drainage will be different. Intralobar sequestration will drain into pulmonary veins. Extralobar sequestration will drain into systemic veins. Okay. So there is some anatomy, embryology, radiology integrated. Very likely, this is the kind of question they like putting in the INICET paper as the differentiator. They want to make sure that they are able to somehow differentiate between the students who are able to integrate basic sciences with the clinical sciences. Okay. CPAM will also present with recurrent chest infections. Newborn, X-ray will show air-filled cystic lucencies. The diaphragm will be intact. And there will be no aorta as the blood supply. If the aorta is the blood supply, then it is sequestration. Keep this in mind. You will get an extra question right more than others. Are you able to do it now? Are you clear now? Okay. So once you are able to do it, quickly now let us see the question that I wanted you to. Another of my prediction is last 2024 in the INICET paper, they have gone towards interventional radiology. 2024 INICET paper, first time in the history of the INICET paper, they have asked a question on interventional radiology when they asked about coiling, which is neurointervention. I am predicting GI intervention. GI intervention, remember in your medicine class, portal hypertension. For portal hypertension, for variceal bleeds, we are now creating a transjugular intrahepatic portosystemic shunt, which is called as TIPS. And my prediction is, this is TIPS. So you can see the connection is between, can you tell me? The right, remember, right hepatic, right portal vein. So we are putting our catheter through the jugular vein into the IVC, into your right hepatic vein, and creating a communication with the right branch of portal vein. This is the most commonly done approach. So this is a new question that I predicted based on their inclination to create a new question, and to create a new question they tend to go towards interventional procedures. This is a new procedure that I want you to remember for portal hypertension. Remember, for you might have read this in variceal bleeding or refractory ascites, you might have read of this in medicine, but remember it is a shunt which is between the portal and systemic. Remember, portosystemic shunt. So they are between the right hepatic vein and right branch of portal vein. Clear? Okay. So very quickly I will ask you a question. Let's see if you can answer very fast. Okay, beta. Let's see. Liver is divided into segments by a method called as Conynod segments. Okay. Based on what? Okay. Before we go, all you need to tell me is based on what? Based on hepatic vein and portal veins, not on the basis of artery. Liver is divided into segment based on hepatic vein and portal vein. All I will do is I will predict that they might ask you segment in the exam. Let's see if you can answer better. Always remember middle hepatic vein and draw a vertical line. Beta. Okay, the most commonly the TIPS is done between the right branches. Most common approach is this. You can make other approaches also, but most common I have asked. Okay, so you draw the middle hepatic vein and you draw a vertical line. Then you draw a horizontal line and you call it portal bifurcation. One side is the right lobe, one side is the left lobe. Always remember the rule. Start on the left side. Start on the far upper corner, right, segment 2. So segment 2 is in the left lobe, superior. Then 3 is left lobe, inferior. Now you come closer to the midline, you will see 4A, 4B. 4A, 4B. Are you able to mark it now? Okay, beta. What about your right lobe? because they like integrating radiology and anatomy. So that is why I'm only focusing on those things. What about the right lobe? They will start closer to the midline, and inferior. You will start at 5, then you will go clockwise 6, 7, 8. So right lobe, you go clockwise 5, 6, 7, 8. 5, 6, 7, 8. This is how you do the labeling. Again, one of my predictors for the INICET is in the hepatobiliary system, they might go for an ultrasound, MRCP, they might go for a TAPES question, ERCP question, or liver segments. Because the method that they are following is they want less question in short subjects, but whatever they want to put it very quality. They want to make either a match the following, a trauma question, emergency question, HIV question, hepatobiliary intervention, neurointervention, or something to do with anatomical variants like an aberrant right subclavian artery causing dysphagia lusoria. They love putting anatomy radiology integrated in the paper. So I would strongly recommend that if you have not done it, I have discussed all the radiology questions in the app in the section called as PYQ ka BAP 3.0. I have discussed the recent questions and my predictors there as well. If you have not done it so far, it is a very, very good idea to do mission INICET from your short courses for the predictors for the exam. Please keep doing the mock test and the test to get the feel of the paper. But these are the special type of paper. I'm just going to explain to you once more. Around 50 MCQs in your paper. 150 will be single best answer. 50 MCQ will be different types of MCQs, which I have shown you in my discussion today. Multiple combinations, arrange in sequence, match the following, assertion reasoning, image based questions. So I hope this gives you the idea, and I have covered everything in these two papers. If you have not done them so far, I would strongly recommend that you do it. And also remember a beautiful thing that I read today, and I thought I should talk about it before we close the session for the day. I look forward to meeting you, by the way, on this channel 10 a.m. every day. So please be there at 10 a.m. 5-10 minutes. We will have some good energizing talk together. Today I was reading and I read a line that somebody wrote that I felt as an imposter. Okay? So I read this line on social media that somebody said, I felt as an imposter in the world full of so many good people. And I thought, just like a medical student, remember, just like a medical student or a doctor, when I first entered my medical college, when I entered Maulana Azad Medical College, Delhi, I was like, yaar boss, अपन यहाँ पे कैसे करेंगे? I am an imposter. I am not that good as all of these people are. But the wisdom is realizing everybody else is also pretending. Everybody else is also imposter. You need to beat them. You can do it. So don't think कि ये एक बड़े कॉलेज का बच्चा है, ये कोई और है, वो जीतेगा, मैं हारूं, ऐसा कुछ भी नहीं है. It is in your head. It is in your head. You are thinking you are imposter, but everybody else is an imposter. You need to beat them. You need to beat them. तुम कर लेगा, मैं बता रहा हूं. You will be the best. Can you keep it in your mind? Yes or no? Yes. I am sure you can do it. I am sure you can do it. But are you sure? As a teacher, I am sure that you will do it. And only thing that I am asking you is, only thing I want from you, and you have to promise me today before you go. I want from you is, when you appear for your INICET paper, don't think about the outcome. Enjoy the paper. Don't think about the outcome on the day of the exam. Give the best exam of your life. And come back and tell me, sir, no regrets. Okay, so I want you to remember that, outcome is not in our hand. Or whatever we may try, howsoever we may do, it is not in my hand. So don't think about the outcome. Only think about one thing. And that is the promise that I want you to do and tell me. The promise is that you will go and give the best exam of your life, come back with no regrets. रैंक आएगा वो बाकी देखी जाएगी. बट विल यू कम बैक एंड टेल मी, सर मैंने मेरा बेस्ट किया, मुझे कोई रिग्रेट नहीं है. विल यू कम बैक एंड से दिस बेटा कि सर मैंने मेरा बेस्ट किया, मैं जो कर सकता था कर लिया मैंने. एंड दिस इज व्हाट आई वांट फ्रॉम यू. जब वहां पहुंच जाओगे, मजा आना शुरू हो जाएगा, जिंदगी बदल जाएगी. द एंटायर आइडिया इज दिस, गिव योर 100%, leave the rest to one who is bigger than all of us, and go all out. Come back with no regrets. I wish you all the best. I truly enjoy my time teaching you. It makes my life worthwhile. और जब आपको मिलता हूं और आप बोलते हो कि सर हमारी जिंदगी में आप कुछ कर पाए, that makes my life worthwhile. I look forward to meeting you all, बेटा. I wish you all the best, बेटा, from my heart. God bless you. Keep reminding yourself, अपना टाइम आएगा नहीं, अपना टाइम अपन खुद लाएगा.